Hi friends. So first of all, we are dealing with respiratory system. Respiratory system and its embryology as well as its congenital anomalies. You know. So first of all, respiratory system. Respiratory system. We know that it consists of lungs. So lung is formed as a form of lung bud, at the fourth week. It's very important date. Fourth week, lung bud will be formed. Where? In the foregut. We know there is foregut, midgut, hindgut and stuff. So in the foregut, we have lung bud formation in the fourth week. After that, it undergoes into four stages. One is pseudoglandular. Other one is canalicular, saccular, next one is alveolar. So there is four stages in which the lung is being formed. Okay. So I'll explain the whole four stages. It's very easy. The name suggests what it is and all. So it's very easy to understand. First of all, the lung, we know that the respiratory system consists of trachea, there is this bronchi, there is this bronchiole, it is terminal bronchiole, after that there is respiratory bronchiole, after that alveolar duct, after that we have saccule, and it is divided into alveoli. Right? So this is a process. We are just naming it. We know this process. There is trachea, bronchi, bronchiole. So first of all, trachea has ring-shaped cartilage. We have here bronchi, after that bronchiole. So there's a difference, okay? Bronchi has hyaline cartilage. Bronchi has hyaline cartilage. Bronchiole do not have any cartilage. We have to know that. It's just epithelium and smooth muscles. There is no cartilage in bronchiole. So it will be terminated in terminal bronchiole. After that there is respiratory bronchiole. After that alveolar duct and sac and stuff. Okay. So up to terminal bronchiole, in pseudoglandular stage, the growth is up to terminal bronchiole. It will be looking like a gland. That's why it is known as pseudoglandular stage. And it's only up to terminal bronchiole. So there is a speciality from trachea up to terminal bronchiole. There is a speciality. This speciality is that it is only conducting air. It is not part of respiratory system. I mean, it is part of respiratory system, but it doesn't undergo respiration. That means there is no gas exchange. That is the main process of respiration, right? There should be a gas exchange between what? Between the respiratory tract and the blood vessels. But they do not undergo the gas exchange. It is just conducting the air. It is transporting the air, but there is no gas exchange. That's why this part is known as conducting what? Conducting zone. It is also known as anatomical dead space. There is physiological dead space. We'll deal with that later, but here it is known as anatomical dead space because in anatomy, this part is dead towards what? Towards respiration. So that's why it's known as anatomical dead space. Okay. It is anatomical dead space. It is also known as conducting zone. After that we have respiratory, bronchiole and alveolar duct and this alveoli. So it is up to here in pseudoglandular stage. It is from 5th week. We know that in 4th week lung bud is formed. 5th week to 16th week we have pseudoglandular stage. After that, from 16th week to 26th week, this is an important number. We have two important numbers, 4th week and 26th week. So 26th week, after that, it is 16th to 26th week, that is canalicular stage. Canal means there is a canal, there is a duct. It is up to alveolar duct. What? Is respiratory bronchiole and alveolar duct is formed in the canalicular stage. So we know that respiratory bronchiole and alveolar duct undergoes the respiration because from respiratory bronchiole up to this thing, it's known as respiratory zone. We know this, right? This is conducting zone, this is respiratory zone. So in the canalicular stage, they start forming what? Respiratory zone. So we have respiratory bronchiole and alveolar duct. So after 26th week, if the child is being formed, the child can be born prematurely before the actual birth should happen. If the child is being born before that, if it is after 26th week, the child has possibility for survival. If it is before 26th week, the possibility for survival is very less. So, because why? Because the respiratory part is being formed in canalicular stage. So, if it is after 26th week, it can undergo respiration. The child can undergo respiration. But if it is before 26th week, it is very less chance for survival. Anyway, that's what 26th week is very important. After that, from 26th week up to birth, we have saccular stage. What is saccular? Sac. There is a sac-like structure formed, right? So there is sac being formed. Terminal sac is formed, or primitive alveoli is formed in saccular stage. After that, we have alveolarization, which is after birth. It is after birth. It is said that it continues up to 10 years of age or maybe 20 years of age. So alveolarization is a formation of septa. In the sac, there will be septa formed, or a wall-like structure formed, dividing it into compartments called alveoli. So alveoli is being formed. So this is what the whole stages of lung development. We know all this stuff. So what is helping in lung to form this lung bud into forming this mature lung? What is helping it? So it is the amniotic fluid that is helping it. How is it helping? It is known as fetal respiration. We know this respiration, breathing in and breathing out and gas exchange and stuff, but it's not the fetal respiration. Fetal respiration is the aspiration of the amniotic fluid, which is helping in the formation of lung bud into this lung. So there is amniotic fluid that is helping. And also we have to know some special cells in this. There is goblet cells which is producing mucus, and there is this goblet cells produces mucus, and this mucus is being escalated with the help of cilia that is in the epithelium of columnar epithelium, pseudostratified and columnar epithelium of this of this bronchi and trachea has this cilia, which will help in escalated movement of mucus upwards. The mucus will trap the particles and it will be transported upwards by the cilia. So that's there. And then we have special cells called club cells. Club cells, what is this? It is club cells that is fighting against the toxins. The toxins are being destroyed with the help of cytochrome P40 of P450 of club cells. Okay, so we know there is goblet cells and there is club cells, and there is two cells in this alveoli, which is pneumocyte type 2 and type 1. Type 2 and type 1. So type 1 is a squamous cell and type 2 is a cuboidal cell. Type 1 helps in gas exchange. Type 2, so that's what the main function of alveoli, right? The gas exchange by type 1. Type 2 produces surfactant. What is it producing? Surfactant. And also it is a stem cell. So what is surfactant? Surfactant is something that reduces the surface tension. It is what reducing the surface tension. So we know that alveoli has a tendency to collapse. It has a tendency to collapse. It's like a balloon. So when we put the air inside, and we leave the opening, this balloon will collapse, right? It has a tendency to come into its original position, the recoiling property. So alveoli has a property to collapse, but this property to collapse is being maintained. It is stabilized by the surfactant. It is being reduced by the surfactant. How is it reduced? The surfactant will reduce the surface tension. We know a formula called it's a law called the law of Laplace, which has a formula P is equal to 2T by R. So when R is reduced, the P is increased, right? The pressure is increased. It will collapse. But to stabilize this pressure, we will reduce the tension. What is this? Surface tension. How is it being reduced? By production of surfactant. Okay. It is this surfactant is being produced by the type 2 pneumocyte. Also, there is lamellar bodies in this. The pneumocyte type 2 cells have lamellar bodies, which is producing the surfactant. Also, the type 2 pneumocytes are stem cells. When there is a lung damage, this type 2 pneumocyte will proliferate and will form. It will differentiate into type 1 pneumocytes. So this type 2 pneumocytes has two functions. One is production of surfactant. One is that it is a stem cell. So that's what the type 2 pneumocytes is all about. It's like a guard, and also the club cells are like guard. It also produces some components of surfactants, and it will fight against the toxins by cytochrome P450. And also we have goblet cells, which is producing mucus. These are special cells of special cells of respiratory system. And we have to know that surfactant has two components known as lecithin and sphingomyelin, and which should be more than or equal to 2. Lecithin is a major component, sphingomyelin is a minor component, and this ratio is being calculated for looking into fetal lung maturity. The lung will be matured enough. How can we say that? It is being measured by this ratio lecithin by sphingomyelin, and lecithin has DPPC. As a major component of lecithin, it is called dipalmitoyl phosphatidyl chloride, DPPC. Okay, anyway, lecithin by sphingomyelin ratio should be more than or equal to 2. That's when we say the fetal lung maturity is enough. But if it is less than 1.5, it will show NRDS. We'll go into that. Anyway, this is the embryology of respiratory system. We have 4 stages, and we said 4 special cells also. Okay. Now we'll deal with congenital anomalies. Congenital anomalies. Congenital anomalies in this respiratory system. So we have pulmonary hypoplasia. We have bronchogenic cyst, and we have NRDS. These are the 3 things we'll deal with. So these 2 are the congenital anomalies, and NRDS we will deal with in embryology itself. So thing is that pulmonary hypoplasia. What is pulmonary hypoplasia? The lung is being what is hypoplasia? Reduced number of divisions of the cells, right? Hypoplasia. So what is pulmonary hypoplasia? Reduced number of cell divisions in what? In lungs. So the lung is not able to form from lung, but it is not able to form the lung. Why is it not able to form? Maybe we said we have fetal respiration, right? Fetal respiration requires amniotic fluid, which will help in the formation of this lung. But if amniotic fluid is reduced, then the lung cannot form. So there is pulmonary hypoplasia. Or otherwise, it is forming in this direction. But if there is a push from this direction, due to some something that is pushing it, so that's why there will be pulmonary hypoplasia. So there is 2 conditions. Logically, we don't have to mug up anything here. So pulmonary hypoplasia will be formed by 2 things. One is Porter's sequence. What is it? Porter's sequence. Second one is there is diaphragmatic hernia. What is Porter's sequence? What is diaphragmatic hernia? The thing is that we said amniotic fluid is reduced. Why it is reduced? Where there is kidney dysfunction, and therefore the amniotic fluid is not there. Therefore the lung cannot form into mature one. So there is pulmonary hypoplasia there. So this is known as Porter's sequence because of kidney dysfunction. It is known as Porter's sequence. The next one is diaphragmatic hernia. We know now under this lung we have diaphragm, which will have some hernia. Some GI components will be protruding outside, so there will be a push, which is therefore the lung cannot form into mature lung. So there is 2 conditions. We know that. It is very logical. Next one is bronchogenic cyst. So what is bronchogenic cyst? We said there is lung bud but there is an extra lung bud. For lung we need a lung bud, but there is an extra lung bud being formed, and that lung bud will remain as a cyst. There will be fluid inside. That's what cyst means, right? So there will be fluid inside, and this will remain as a cyst, and this will be asymptomatic. There will be no symptoms in this, but if it is infected, it will contain air. It will contain what? It will contain air inside. So maybe it can be infected, but it's mostly asymptomatic, and sometimes it compresses the airway. Airway compressions will be there. We know that it's adjacent to the lung that is formed. So maybe they will compress the airway. So it's mostly asymptomatic. That's what bronchogenic cyst is. That's what pulmonary hypoplasia will deal with it. Next is NRDS, neonatal respiratory distress syndrome. Why is there a distress into respiration for the neonatal, for the newborn? Why? Because the surfactant is reduced. We have said this thing. The surfactant is reduced, right? So it is reduced. How much it is reduced? We said lecithin by sphingomyelin ratio is something that denotes fetal lung maturity. But if it should be more than or equal to 2, we said that. But if it is less than 1.5, then it predicts NRDS. It predicts NRDS. If surfactant is reduced, there will be NRDS, neonatal respiratory distress syndrome. What are the risk factors for NRDS? We have risk factors, that is, we have premature birth. We said surfactant is produced from 26th week to 36th week of gestation. If it is premature birth, if the child is being born before 26 or something, then or in between there, it is a premature birth, then surfactant is not there, right? Surfactant production is not there. So that's why it is very reduced. So that's why premature birth is a risk factor of NRDS. And then we have diabetes of mother. Diabetes of whom? It's not child, it's of mother. If there is diabetes of mother, there will be production of insulin by the child. And if insulin is produced, there will be reduction in the surfactant amount. And we have cesarean birth. So if there is a cesarean birth, there will be compression. And if there is compression, there will be less production of cortisol. We know that for surfactant production we need glucocorticoids and cortisol and stuff. But if it's reduced, then we'll have a reduced surfactant production. So that will lead into NRDS. So there is 3 things that is a risk factor for NRDS. One is premature birth, diabetes of mother, cesarean birth. And what are NRDS causing? They are causing 3 things, RIB, and also they are causing PDA. What is RIB? It's not MIB, it is RIB. And RIB denotes retinopathy, intraventricular hemorrhage, and then bronchogenic dysplasia. What is retinopathy? The retina is being detached. Why? Retina is being detached, and it will cause what? It will cause blindness. And there is intraventricular hemorrhage, there is bronchogenic dysplasia. It's all easy. Anyway, and also they can show patent ductus arteriosus, PDA, patent ductus arteriosus. What is patent ductus arteriosus? You know that aorta is there, pulmonary artery is there, so there is shunt between this thing and this blood from pulmonary artery will go into aorta in the fetus. But after birth, we know that the pulmonary vascular resistance is being reduced very much, so that aortic pressure will be more and the aortic blood will be transferred into pulmonary artery. So this is what happens. But thing is that why is it staying here? Normally, when oxygen concentration is being increased after birth, right? If it is being increased, this ductus arteriosus should close. But if there is a problem to the lungs, then the oxygen will not be increased, it is reduced only. So if there is oxygen concentration very low, this ductus arteriosus will remain patent, and this is known as patent ductus arteriosus. And since the pulmonary vascular resistance is reduced, the blood flow is from ear to ear, right? So this is patentectus arteriosus. Just saying it. So NRDS can cause patentectus arteriosus also. So there is three things that NRDS can cause: retinopathy, intraventricular hemorrhage, bronchogenic dysplasia, and patentectus arteriosus. This is all about embryology and congenital anomalies of respiratory system. Next, we'll deal with anatomy in the next video. Thank you.